Good morning. Thanks for joining us for this review on PJK. It's one of the most all-encompassing issues that we have to think about when we plan our surgeries. We'll kind of review some of the literature and present some new stuff that's been going on as well. The incidence of this problem is increasing over time as we see more and more the aging demographic. There's different reasons to develop adult deformity. It can be a sequela of idiopathic scoliosis from youth or residual deformity, and it can also be from degenerative issues. Along the spectrum of the degenerative cascade in the spine. The treatment of the deformity requires a lot of planning, and when it's deemed to be a surgical problem, will require long segments, instrumentation, and fusion. This is one of the most dreaded complications, which we call proximal junctional kyphosis, resulting from the adjacent segments breaking down, failing over time, as typically at the either top of the construct or the segment above the upper instrumented vertebra. Some definitions will review, but we generally say at least 10 degrees of deformity, or typically kyphosis at the top, compared to the preoperative kyphosis at that segment. So in other words, basically at the top where the metal ends, a complication can occur where you break down over time and get bent forward over that top screw. Radiographically, this can be a finding that doesn't have symptoms, but when it does become problematic, it can manifest in pain, which may be from a variety of etiologies. It could be from the disc base breaking down. It could be from postural deformity through where the collapse is, the kyphosis. You can get stenosis or instability from ligamentous complex attenuation or disruption, or even fractures of the body. When you do require surgery, you typically are extending the fusion proximally and trying to correct the deformity at the level that has failed. There have been several definitions that people have tried to characterize the PJK. The most commonly cited one, this is the number one most cited paper in the literature on PJK, is the Galatz definition that was published in 2005, saying the Cobb angle has to be greater than or equal to 10 degrees and at the two superadjacent, between the UIV and the two superadjacent vertebrae, compared to the pre-op measurement. The Galatz study was out of WashU, comparing the preoperative and final postoperative radiographs, and then also correlating that to SRS-24 outcome scores. So proximal junctional kyphosis between the UIV and the cephalad end plate of the two UIV plus 2. So they looked at 81 adults, and they measured somewhere around 26% of cases ended up having some PJK. On average, that mean Cobb measurement was 19 degrees. And they saw at T3 stopping point in their series had the highest amount of PJK. The incidence overall varies dramatically in literature, up from 17 to upwards of 62%. But most series, somewhere in the 20 to 40% is the bulk of them. The timing of PJK is also something that seems to happen relatively early. 80% will occur within the first year and a half. Part of why there's such a huge range in the incidence is because it's a very complex problem that has contributions from multiple risk factors. In this study is from 2018. 314 patients were followed for 2.5 years. And mean 2.5-year follow-up, and they measured 25% had PJK in this cohort. Looking back at the patients that did have PJK, they concluded that age older than 50, higher BMI, they used a cutoff of 25, which is a little odd. And then higher pre-op pelvic tilt was another radiographic measure. It seems to increase the risk of PJK. Overall, despite the 28% incidence, they only did revisions in 2.3%. Out of those 2.3%, 15% of the cases were for PJK, so relatively low revision rate in their series, like less than 1% were for PJK. The other reasons for revision had to do with infection or neurologic stenosis. This was a 2016 meta-analysis looking at 14 total studies with 2,000 plus patients, and they cited the average PJK rate was about 30%. Here's their forest plots of the significant risk factors they found. Most of these were only, somewhere between 2 to 6 papers. So for these individual risk factors, there isn't like an overwhelming amount of data looking at their individual contribution versus if there's some confounders. But their risk factors that they found: age, long fusion ending at S1, pre-op kyphosis across the T5 to T12 segment, low bone mineral density, as well as pre-op sagittal balance over 5 centimeters, which is the higher end. You can see from the forest plot that the age and the thoracic kyphosis were the two largest odds ratios they reported at 2.7 and 2.2. Actually, sorry, the 2.5 for the SVA difference was the highest, but there's pretty limited sample size there. In terms of the risk factors, generally we think about them in broad categories. One is kind of a pre-op radiograph measures, which is indicative of their biomechanics or their imbalance prior to surgery. Second is the host and patient-related factors, their healing potential. And third is surgical risk factors related to the technique. Radiographically, the sagittal malalignment is now taken into very careful consideration. Choosing a upper instrument vertebra is still controversial, and there's several factors related to their overall health and comorbidities that kind of give us a sense of how likely they are to break down. And then surgeon-specific decisions, a lot of variability as well, but considering what type of approach in terms of the front and the back, how rigid to make the construct, how many rods, how high to go, how much correction, as well as your goal for postoperative global alignment. This amount of consideration requires a lot of pre-op planning. So thinking about all these things, it's not really something you can do all within the time frame of surgery. Historically, it seemed to be thought that PJK was just a radiographic finding, and it's something that just happens after surgery. And less was described about the biomechanics contributing to it. I think now there's more consideration that it's a clinically significant problem. But in essence, it's a spectrum of disease. It can be just benign minor changes in the disc, or at worst, it can be complete clinical failure with either fracture or instrumentation pullout, with issues with pain and neurologic symptoms or worsening posture. This study was in from 2013, trying to look at upper back pain specifically as a marker of PJK, if to see if it correlated. And essentially, from this study, basically no patients without PJK had reported upper back pain. So upper back pain is a fairly uncommon problem for patients with no issues radiographically. 30% of the patients who did have radiographic PJK did report some upper back pain. So not all PJK is going to have symptoms, but around 30%, this upper thoracic pain is a pretty specific finding, should tip you off on the exam. In response to this, strategies to mitigate the risk of PJK have been greatly debated and becoming more and more discussed. Things like using vertebroplasty or augmentation, as well as being mindful of the costs, as any revision occurrence is very economically impactful. So reducing the cost of revision surgery can be a huge driver for PJK research. In terms of classification systems, this one was proposed by Yagi. 3 types of PJK: ligamentous failure, bone failure, or implant bone interface failure. And then subtyping by kyphosis, as well as spondylolisthesis. Interestingly, in their series, this complex spine study group, they reported adjacent segment disease to be only 1.4%, in a relatively large series of 1,668 patients. Only found 23 patients with PJF. And then classifying the failure, it was most commonly through fracture at the UIV +1. And then their largest risk factor that they saw was a larger degree of sagittal correction between pre-op and post-op. This is another classification by the SRS Adult Spinal Deformity Committee, grading the severity of PJF based on their symptoms: neurologic deficit, pain, instrumentation failure, kyphosis, and fracture. And their goal was to calculate a score that may be able to use to be guiding treatments, although there wasn't a strict consensus on what score would necessitate intervention. Other prophylactic measures, different types of hook constructs to soften the landing up top, so there's a less abrupt transition point. Some theories or philosophy discussing erring towards undercorrection rather than overcorrection. And then also along those lines, having age-adjusted targets, although this has been disputed, and we'll talk a little bit about that. Because asymptomatic age doesn't incorporate degenerative changes, and so the goal to correct towards a degenerated spine is not necessarily optimal. Other ways we just talked about this a little bit, but other ways to mitigate risk, looking at bone health. Hounsfield unit has become published as a relatively useful marker for bone health. It's not perfect, but it does give you some idea of the degree of osteoporosis, whether you might want to upsize screws at that level. And there's some interesting research looking at finite element modeling that's coming out now, as well as looking at biomarkers for planning bone health. A lot of merging evidence from the endocrinology world. teriparatide or Forteos, probably the most well-known advancements, now used pretty frequently, as well as for fragility fractures in the pelvis. And it's exciting because this offers a solution to correct a modifiable risk factor. This study looked at 43 patients versus 33 controls and found reduced rates of PJF. And they did this post-op. So they saw some benefit in possibly contributing to both bone strength as well as and subsequently with fusion. In terms of using hooks, historically before pedicle screws, hooks were often employed. Definitely have seen tons of hook-only constructs that fused quite nicely from AIS patients. They would hook to the transverse process at the UIV. So hook-only constructs versus using hooks at the top, hybrid constructs. And it do demonstrate lower incidence of PJK relatively within 22% with hooks only versus 35% versus in pedicles only. But it's a pretty small sample size, and the range can vary quite a bit. There's been a lot of risk calculators trying to stratify the relative importance of known risk factors. But if you look at these rankings that they find through statistical forward or backward regression, most of these variables are trying to estimate different aspects of global sagittal imbalance. So ultimately, that's what all the risk factors, multiple risk factors, are sort of confounding. In the sense that needing to do a PSO is already sort of accounted for in probably having a bad mismatch or sagittal imbalance pre-op. Postoperatively, sagittal vertical alignment as well as changes in thoracic kyphosis have been found to be significant in this study. So they advocated for flexibility of the spine as an important pre-op consideration to see if the thoracic spine should be able to compensate for changes in lumbar correction. Because if not, then this may require thoracic osteotomy and extensions to the upper thoracic region. So another study demonstrating that the optimal, this was another study demonstrating optimal alignment postoperatively. They proposed that you should be looking at the UIV femoral angle, which is they estimated should be with less than 11.5 degrees based on their series. But this angle is dependent on pelvic tilt, so somewhat of a moving target, but can give some insight into changes in the compensatory mechanisms after surgery. This was something I hadn't heard of, but was recently discussed at the IMAST. It seems like it's not a popular technique, but some people have been describing doing these tethers going through the spinous processes at the UIV and UIV proximal to the UIV. There were, I think, 15 studies, but almost all the techniques described were different. But here's a nice, almost this basically like a sports procedure trying to use some kind of soft tissue tensioning procedure to smooth out the transition from the metal into the native ligaments. They did some finite element modeling that suggested the more gradual distribution of stress is better with more levels tethered. However, you do have to expose more soft tissue to get these tethers in, and that may confer some loss of stability as well. Tensioning techniques of how tight to pull these tethers, just pull as tight as you can versus using some kind of ratcheting mechanism tool is also one way to do it. Ultimately, they're highly variable methodologies, but most of them showed some reduction in PJK. So it'll be interesting to see if some of these constructs become more popular as they're studied and better validated. Here's sort of their range of PJKs, but again, somewhere between the 20 and 40% range, mostly with some of them reporting much lower rates, even 0% in some, but in kind of 2-year follow-up. So it's interesting. I looked at that for a while. And then ultimately, I think this is this is what our group uses the most from a philosophical, religious standpoint. Goal here is to understand what the optimal alignment should be. And the T4L1 hip axis is something that was observed in asymptomatic, normal, non-degenerated spines in a cohort of patients taken off the street. And this correlation between the T4L1 pelvic angle was found to be the strongest in these normal alignments, despite different types and phenotypes of curves or Russley types. And the nice thing about pelvic angle is you don't need to make measurements like the centimeters, which need to be calibrated in the intraop films. It can be hard to measure with the hips and along the scoliosis film. So you can make these measurements without any calibration intraop. And this accommodates different distributions and shapes of curves. The validation continues to be important, relatively new measure. So we'll see as more data comes out, the relative reduction in PJK is starting to be published on. Interestingly, at IMAST, when they were surveying the audience at this little case discussion, I would guess it was like a third of people said they were using this, and then it seemed like another third were just looking at PILL only, and another third seemed to have their own ideas of how to measure. But the overall idea is that this is a better understanding of optimal alignment. Undercorrecting to the age is still going to lead to persistent compensatory mechanisms, which eventually, once they run out of compensation and they're out of that harmonious cone, this could accelerate adjacent segments problems and stress the hips. And the sagittal balance will eventually fail if we're not close to that optimal balance. So all the other techniques in mitigating the PJF is probably not as important as balancing the mechanics. And then on the other hand, overcorrection is also known to be increasing the rates even higher for PJK. So maybe that there was some pendulum swinging that overcorrection was bad, and then people started undercorrecting, and now we're starting to say neither are acceptable. When to intervene is very difficult. As we presented, a large percentage of these patients are asymptomatic. All other times, patients are presenting after prior fusions, and though they may be minimally symptomatic, it can be often easier to intervene earlier rather than later. knowing that most PJK will happen within the first year and a half if they're already symptomatic early. There's definitely some consideration that surgery is likely a lot easier early on before there's excessive scarring, before fusion bone mass may make osteotomies a little more difficult. There's more flexibility. So I think there's still a lot of question when you're confident that intervening is the right decision. And some of these pre-op alignment goals are definitely helping us make that decision. In this paper, there are 57 patients who underwent revision surgery for PJK. 47% had surgery within 6 months. Some of them were sustaining trauma that led to PJK, so slightly different cohort. If they have an acute fall and they fracture above, I think that is not, with a compromised upper vertebral segments. I think that would hasten your return to the OR. They also saw the combined anterior posterior approach seemed to increase the risk of revision. Again, this doesn't take into account what their pre-op alignment goal was and what they got. So some confounding between these variables. And then ultimately, along with a lot of other papers, a greater degree of correction in surgery was thought to be related to PJK, which made people think that overcorrection was the issue. But in essence, in some ways, greater sagittal imbalance pre-op is you're naturally going to want to fall back towards where you were. So competing interests there in terms of trying to get the best correction possible. In this paper, patients that did not have neurologic symptoms but underwent PJF surgery were evaluated for risk for further revision. 63% of the patients who had bony failure and high proximal junctional angle of around 22 degrees ended up requiring further revision. So looking at the PJA between pre-op and post-op, as well as progression to this number, somewhat helpful in trying to better understand if there's a cutoff number that could suggest surgery is helpful. GAP score is another one that I heard discussed. I looked that one up. Again, measuring all these markers for global alignment, but all of them together sort of paint the same picture and can be highly correlated. Not a great validation. Several studies evaluating it showing it did not predict who needed surgery or who didn't. So good way of looking at things that matter, but not necessarily putting them all together to come up with something. Interesting, all these scoring systems, like the same group of people have proposed all these different ones. So if they're coming out with new scoring systems and classifications every few years, they're sort of all in agreement that there isn't a validated, agreed upon scale just yet. But obviously, this is a big problem. Lots of research has gone into this. The discussion it seems to change. 5 years, 10 years looks completely different. X-rays, the number of X-rays that people are arguing over seem to be increasing as we identify more things that appear to matter. But it's a common issue with multiple contributing factors. I think the patient-specific optimal alignment goals are starting to gain more traction at the expense of more cost. Collecting more data and understanding sagittal balance is definitely going to contribute to finding better goals. as well as correlating that to quality of life and healthcare outcomes. So it'll be exciting to see in the future. Even in 5 years, I expect there to be different findings and shift in philosophy. So, but I think more and more the concept of preoperative planning and using technology to simulate is I think in the long term will definitely make at least the alignment goals more closer to being achieved, and also helping guide what we need to do in surgery, what you should be able to achieve with correction, and hopefully measuring the introp correction. I think that's an inertia thing. I do feel like getting the flat plate and the scoliosis long film seemed like people were arguing about doing the stitching not being accurate, and it does feel like a huge holdup in the middle of surgery. So I think if there's ways and there should be ways to calculate your correction without that's less bulky. I think that'll definitely get more people interested in checking intra-op rather than just post-op. So but definitely a lot of advancement and drives the complexity of deformity surgery.
So, hey, David, without any preconceived judgments by your mentors currently or prior, after looking through all this, how are you feeling about the best means of assessing sagittal profile, sagittal alignment? How do you target best?
Yeah, I think
it's settled science.
I don't think so. I mean, even if you look at the Kelly Harms study stuff, the error margins, they're not crazy, but they're there. All the correlation. I think Tim brought this up early, or one of our Australian fellows, but the R-squared value was not super high. I mean, the trend was definitely there, but making the there's another study just at the Banff meeting we just went to where they were saying, oh, the optimal goal should be something plus 5 degrees or something like that, something crazy. And it's just like, you can't even measure within 5 degrees of accuracy, inter-rater. Right. So saying something has to be within 10 degrees is still really hard to get right. I think even with how they were measuring PILL in the back. So measurement is and position is always going to make it hard. And then this concept of huge correction predisposing to failure makes it hard to know, even if you know the optimal alignment, should that always be the goal? So I think there's a lot more to know, but I think the T4L1 stuff makes a lot more sense than just slapping on a PI minus LL and then just having the regression linear equations that say just input your parameters here and you'll get your optimal LL or whatever. So I think the thinking of the biomechanics has definitely gotten a lot better. I think the finite element analysis stuff, if we can get that right, simulating how much stress with considering the soft tissues as well, I think that'll maybe give us a better understanding too, but I'm not sure how we get there. But definitely a lot of smart people are interested in this topic, so it's exciting.
David, just want to bring some historical elements to this. That once you're talking about these complex measurements and corrections and techniques, just think about a few things. One is, if you don't do surgery, there's no PJK. And I think that's one important thing you always have to remember. The PJK starts with our surgeries. And we do something in surgery that makes things happen and makes the PJK happen. So without surgery, we don't have one. And I think, we just going back to the Harrington era, really, we didn't see a lot of PJK. And we had a lot of flat back. We had a lot of malalignment or sagittal alignment. And what was the reason for that? And I think there's also some that you mentioned that there's a radiologic PJK, but there's no symptoms. And why they're not symptomatic and why they don't need surgery. And at, at the end, I think we are talking about, obviously, initially to overcorrection was causing this. And now under correction, you're talking may,
Oh, here he is. Never mind. Bye.
maybe,
How are you?
it's
Good morning.
as well.
How are you?
And maybe someday
Good.
alignment, it doesn't matter, and something else. So you have to really keep our eyes open to any possibility. And I agree that it's a complex issue, and hopefully one day there will be a solution of solving this issue. So just wanted to, just as you're discussing, keep those things in mind.
Yeah, it's interesting. So at the AO Banff course, one of the local hosts, I guess, is a Calgary spine surgeon. And he was the fellow at UCSF when I was doing my research year there. So I was doing the measurements for him back then. And we were discussing this stuff. And so I feel like kind of lucky, like 10 years ago, I got a peek into it, and now showing up this year feeling like I didn't know anything. So definitely it's changed the mindset. But it seems like the literature a little bit is kind of the approach in the philosophy is very almost divergent, like multiple concepts can be conflicting. So yeah, I think once there's a better agreement amongst the community of what matters, what doesn't, I think it seems like it's heading that way. Hopefully the research will be more additive rather than going different directions. But definitely a lot of invested people in this. Thanks for joining us. I guess everyone have a great day.